Hello and welcome to my channel. We'll continue our talk about the upper limb in this lecture, so let's begin. We've reached the level of the cubital fossa. This is the cubital fossa you see here. The boundaries of the cubital fossa, the base is an imaginary line passing through the medial and lateral epicondyles of the humerus. This is the base. And the medial border is the lateral border of the pronator teres muscle. So the pronator teres is not included in the contents of the cubital fossa because the medial border is the lateral border of the pronator teres. The lateral border is the medial border or the medial margin of brachioradialis muscle. The floor formed by the supinator muscle laterally and the brachialis muscle medially. Okay, roof is formed by skin and fascia, the bicipital aponeurosis we learned earlier, and the cubital veins and the medial cutaneous nerve of the forearm. We talked about these structures in the last lecture. The contents of the cubital fossa is the brachial artery. Put it in a central region. The median nerve will be medial to the artery, and this is a specimen of the left arm, by the way. This is medial and this is lateral. The brachial artery is central, the median nerve is medial, then the tendon of biceps and radial nerve lateral. So when you use this sphygmomanometer to measure the blood pressure of a patient, you put the stethoscope medial to the tendon of biceps. Now, this is a fatal mistake in clinical exams if you put the stethoscope lateral to the tendon of biceps, okay? The examiner will know that you know nothing, actually. So the stethoscope should be put medial to the tendon of the biceps to listen to the blood flow in the brachial artery and the pulsations. Okay, the elbow joint. It's a complex joint because formed by three bones, the humerus, the radius, and the ulna. Involves three separate articulations. Actually, it's two articulations that form the elbow joint proper, which is the articulation from the trochlear surface with the trochlear notch of the ulna and the capitulum with the head of the radius with the superior surface of the radial head, while the superior radioulnar joint is the third articulation. It is in the elbow region, not the elbow joint. It's in the elbow region because it's included in the capsule of the elbow joint. Now you got it. Okay, it's of the synovial hinge joint. It's monoaxial joint, only flexion and extension in this joint. And as I told you, it's between the capitulum and head of radius and the trochlear notch of ulna and the trochlea of the humerus. The proximal radioulnar joint, the joint that is included in the elbow region, it's between the side of the head, the disc-like head of radius, and the radial notch on the ulna. All the articular surfaces are covered by hyaline cartilage. Synovial membrane attaches around the articular surfaces. This is the front view of the elbow joint, left elbow joint. This is medial epicondyle, this is lateral epicondyle, and this is a posterior view of the elbow joint. See, this is the articulation. This is from the back, where in extension, where the olecranon fits in the olecranon fossa and the lower hand of the humerus, as you can see here. And here, this is the articulation between the trochlear notch and the trochlea, and on the lateral side between the superior surface of head and the capitulum. Okay, this is the left elbow joint viewed from the medial side. Okay. The capsule of the elbow joint attaches around the articular margins, enclosing the synovial membrane and joint cavities, attaches inferiorly to the annular ligament of radius. Now, please, the capsule and ligaments on the medial side attaches to ulna. But on the lateral side, like the radial lateral ligament, for example, and the capsule of the elbow joint, attaches to annular ligament. Why? Why do we have this arrangement? Because if it's attached to the radius won't be able to move in pronation and supination. Be careful with this. The capsule does not attach to the radius, attaches to the annular ligament, which is around the head of radius. Okay, this is a very a good point. You do not forget this. Okay, annular ligament starts from the ulna and goes around the head of radius, encloses the head of radius, but it's not attached to it. Pardon me, and goes back to the ulna. Capsule forms thickenings on the medial and lateral side, the medial ulnar medial ligament or the ulnar collateral ligament, and the lateral ligament, which is the radial collateral ligament. And there's a pocket of synovial membrane, this pocket, you see it there, to allow for the extension, to allow for the flexion at the elbow joint. This succiform recess that's it's attached to the articularis cupitae, the one we talked about as an extension of the medial head or the middle head of the triceps muscle. The succiform recess, don't forget this recess here, you see it here. The blood supply of the elbow joint, of course, it's the anastomosis around the elbow joint. How is it formed? Two arteries on each side. On the lateral side, there is the anterior descending and the posterior descending arteries of the profunda brachii. First, the profunda brachii communicates with the inferior ulnar collateral. This is one anastomosis. Now, the anterior descending anastomose with the radial recurrent artery, while the posterior descending anastomose with the interosseous recurrent artery. I learned them by heart, you know, the one with the S's together, the posterior descending and the interosseous together, the anterior descending and the radial recurrent. On the medial side, the superior ulnar collateral, also with an S, you know, anastomose with the posterior ulnar recurrent. The inferior ulnar collateral with the anterior ulnar recurrent. Okay, so anterior ulnar recurrent with the inferior ulnar collateral, posterior ulnar recurrent with the posterior ulnar collateral. This is the anastomosis around the elbow joint. You should know it. How is it formed? The nerve supply of the elbow joint for sensation, of course, mainly. Yes, by the way, when we say the nerve supply of a joint, we don't mean movement at all. Nerve supply of muscles involves movement, but a nerve supply of a joint involves sensation from that joint, mainly by branches from the radial nerve, the musculocutaneous nerve, ulnar and medial nerves, because of the Hilton's law of the supply of the joints, nerve supply of the joints. Now we're proceeding to the forearm, the shaft and distal end of radius. The distal end of radius, the radius actually is narrow proximally, as you can see here, expands distally. Okay, expands distally. In the middle it's triangular in cross section and has anterior and posterior and interosseous borders. The interosseous border of the radius is medial. The interosseous border of the ulna is lateral because they face each other for the interosseous membrane. has anterior and posterior and lateral surfaces. The anterior border crosses to form an oblique line, and the pronator teres at the peak of convexity of the radius, the insertion of the pronator teres, there is a tuberosity there. The posterior surface has the dorsal tubercle. This tubercle is called the Lister's tubercle, okay, for the extensor pollicis longus. Lateral surface extends distally as the radial styloid process. This is the radial styloid process. Shaft and distal end of ulna. The ulna is broader proximally. It's opposite of the radius, and the head is distal. Has anterior and posterior and interosseous borders, and anterior, posterior, and medial surfaces, and also an ulnar styloid process at the distal end. You can see it here. Okay, so this is the head of ulna, and this is the head of radius. The proximal radioulnar joint, this one, is a synovial joint of the pivot type. Pivot means it's has a rotation movement. Articular surfaces are the circumflex of the head of radius, radial notch of the ulna, and the annular ligament. The annular ligament, I told you before, it's from the anterior ridge of radial notch of the ulna around the head of radius. It's not attached to, and again, please understand this. It's not attached to the head of radius. Only curves around the head of radius and back to the posterior ridge of the radial notch of the ulna. It's lined by hyaline cartilage because it's a joint there, and the capsule of elbow attaches to its posterior margin. The radial collateral ligament attaches to it too. See, we've mentioned this point before. Now, there's a common dislocation in children, dislocation of head of radius, especially if someone is playing with its child by, grabbing his child from the hands and, spinning him around. This will lead to traction forces on the radius that will dislocate from the superior radioulnar joint, and by simple maneuver you can put back the head of radius in its position. But doctors, once a joint is dislocated, it's more liable to dislocate again. Okay, this applies to the shoulder, this applies to the superior radioulnar joint. The interosseous membrane, it's a joint, yes, of fibrous type. It's fibers of the syndesmosis type, from radial interosseous border down to the ulnar interosseous border. So we are preventing the upward displacement of radius. If we fell on the ground and, on the hand, you will be subjecting the distal end of the radius to the ground with an upward thrust, and the membrane will prevent the radius from going up and actually will transmit the force back to the ulna, which is the steady bone. So it's this arrangement of fibers to transmit forces from the radius to the ulna and dissipate the force the limb was subjected to. It's defective superiorly to allow for the passage of the posterior interosseous vessels. In the lower limb, it's to allow for the passage of anterior tibial vessels. But here, because the vessels originally anterior, so the branches will go posterior through the membrane. Oval aperture at the distal part of the membrane for the passage of the anterior interosseous vessels to anastomose with the posterior interosseous vessels. As I told you, it transmits forces to the ulna, and there's an oblique cord that somewhat in some books is mentioned of unknown functions. It's perpendicular to the direction of fibers of the interosseous membrane, and it's from the ulnar tuberosity to area below the radial tuberosity. Okay, this is the oblique cord or oblique ligament. The distal radioulnar joint is a synovial joint too. It's of the pivot type. This joint, there's an articular disc between the radius and ulna that isolates the ulna from the wrist joint. So the ventral surface or the anterior surface of, or the distal surface of this articular disc belongs to the wrist joint, and the posterior or proximal surface of the articular disc belongs to the inferior radioulnar joint. It's enclosed in a capsule connected by the articular disc, and proximal recess of synovial membrane extends upwards or extends proximal. The articular disc is made of fibrocartilage, triangular in shape. It's from the styloid process of the ulna to the medial border of the lower end of the distal end of the radius. And as I told you before, its proximal surface belongs to the distal radioulnar joint, and the distal surface belongs to the radiocarpal or wrist joint. Now for the fascia of the forearm. There is superficial fascia and deep fascia. Superficial fascia, like the rest of the body, it's continuous. It's of adipose tissue and continuous with the rest of the body, rest of the arm in this case. The deep fascia, continuous with the arm fascia, attaches to the olecranon and posterior border of the ulna, sends septa between muscles. It's thick posteriorly and at wrist joint, and forms the flexor and extensor retinacula. And here you can see the extensor retinaculum. We'll talk about this later in relations of the wrist joint. Okay, so this concludes our talk about this part of the upper limb. We'll be discussing the forearm in the next lecture. I hope you got the maximum benefit of this lecture, and thank you very much for watching.